Thank you everyone for joining us again for our second session. Hope you all had a good discussion for the last session. So as Sripriya mentioned, today we'll be having a first session on pain. So just for you to understand, if you have gone through the schedule, we have a few more sessions on pain managing, especially on management of pain. Today we'll be having an introduction where we'll be covering a little bit of assessment and other aspects of it, followed by the management in another three sessions, upcoming sessions. So today we have as our faculty Dr. Jewell. Dr. Jewell is a radiation oncologist from CMC Vellore, and he's trained in palliative care. And as Sripriya mentioned, I understand he's very passionate about palliative care, and his special interest is community-based palliative care. Uh, Thank you, Dr. Jewell, for being with us for another session. Over to you.
Thank you so much, ma'am. Am I audible?
Yes, yeah.
I hope it's good evening for good afternoon for some of us. Okay, so anyway, I'll share my screen, and without wasting much time, we'll go straight into the discussion. I hope my slides are visible. I'll just put it in slideshow.
Yes.
Okay, so today will be a discussion on an introduction to pain. So I hope to make it less painful for all of you. So let us start. So we have been taught traditionally about pain as a sensation, but medical science has now recognized as pain not merely as a sensation, but rather as an experience, which has myriad of effects in a person's emotional, social, physical, and all aspects of life. So it is important to understand pain as an experience rather than a mere sensation. So that will have an impact on how we see pain and how we assess pain and how we treat pain. So the first thing I wanted to put forward is that we have to see pain as an experience which comes across all aspects of our life rather than a mere sensation. So it is often said that pain is not the nerve endings, but the person who suffers it and their families. So just keep that in mind always. So this recent change of our concept has also been reflected in the definition of pain. So as we all know, we must have all heard about this IASP, International Association of Study of Pain definition, which actually came in 1979. The initial the definition which has stood for around 40 years was an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So after around 40 years, IASB has finally changed this to an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this change in definition has primarily been because of our understanding that for a person to feel pain, there need not be an actual or potential tissue damage. So like, for example, in fibromyalgia, there may not be any identifiable pathology or any tissue damage, or for example, or in phantom limb pain, where there is no tissue at all, left alone tissue damage. So basically, this definition is a little bit confusing, but again, I wanted to focus on this first part. It is an unpleasant sensory and emotional experience. So again, as I mentioned earlier, it is very important to understand pain as a sensory and emotional experience rather than a sensation alone. So this is something that we usually refer to as the pain matrix. So you can see that these are the various areas in the brain that are involved in perceiving the pain as an experience. So you can see that it is actually a very complex network of various centers in the brain. So we can actually imagine how widespread the pain is. Other than being a mere sensation felt by the nociceptors, it is actually a widespread emotional and sensory phenomenon. So adding to that is the concept of total pain, so which has been put forward by Dame Cicely Saunders, who is actually considered to be the founder of palliative care. The palliative care that we know as of today owes mostly to Dame Cicely Saunders. So she actually put forward the concept of total pain. So according to her, or which is the widely accepted concept of pain all over the world, the pain has not only the physical dimension, but also the psychological, social, and spiritual dimension. So all these things come together to form the pain experience. So obviously, because of all these factors, it is very important to keep in mind that pain is very subjective. So it is always important to understand that the same perceivable stimulus or a visible disease in two different persons can actually produce very different kinds of pain experience. So just keep in mind that pain is always subjective. So we all know that pain is a very important problem, right? We must have all gone through the experience of pain in our life, so we know how difficult it is to handle pain. To give you a little bit of context, I'm just taking you through some statistics in cancer pain. So although palliative care is not confined to cancer and pain is a problem in all sorts of diseases, but just to give you some context, I'll take you some statistics of cancer pain. So this is actually the incidence of moderate to severe cancer pain in various stages of cancer. You can see that right from stage 1 to stage 4, all throughout the spectrum, pain is actually an important cause of morbidity. So it is 23.8% in stage 1, which goes all the way up to 50.7, 44.2 in stage 4, and all stages combined, it is around 50.7%. In advanced cancer, it is 70%. So obviously cancer comes, the care of cancer patients comes as an important part of palliative care. So just to give an idea that pain is actually a very important morbidity, cause of morbidity, and a very important thing to consider in various non-curable or progressive diseases. So this is another statistics from 2016. So it again shows that during pain is not only limited to the disease itself. So in this, according to the statistics, throughout the various stages of cancer, including the cancer treatment, and even after the complete cure of cancer, pain continues to be a problem. So I actually showed this statistics to say another thing, because we have to address the question that whether there is a gap in the way that we address pain as an important thing. So do we actually address pain as an important cause of morbidity? The answer would be no, because see, the statistics shows that according to this, in cancer, whenever there is in people, in cancer patients with mild pain, only 50% of them get adequate pain relief. In moderate pain, only 20% of them get adequate pain relief, which comes all the way down to 6% in advanced and not advanced, severe pain. So in other words, around 94% of the people or cancer patients who are having severe pain are not getting adequate pain relief. So the statistics that I showed you previously about the cancer pains present during various stages of cancer was from 2016. So this was actually a follow-up study to another study that was published in 2007. So just compare these two data. And you can see that from 2007 to 2016, we have gone leaps and bounds in the way we treat cancer. So we have had a lot of new drugs, targeted therapy, immunotherapy. We have increased survival, decreased all sorts of things. But you just see that, the incidence of pain actually has only gone up in various stages of the disease. Even after curative treatment, the pain has gone up. So there may be many reasons to this, but it actually shows that pain has not been our priority in at least as far as cancer patients are concerned. So just to give you a context about how pain is a major problem in cancer and in various other diseases, and how we are sadly inadequate in managing this important cause of distress. So having said that, we'll just talk about the pathophysiology of pain. So this is the pain pathway in a very simple form. So as I mentioned earlier, so for pain to be perceived, there need not be a recognizable tissue damage. But for the sake of this discussion, we'll just assume that there is a tissue damage. So from the site of tissue damage, the nociceptors or the pain receptors will actually sense the pain, and they will send electrical impulses to the dorsal horn of spinal cord. From there, the ascending pathways will take the pain to the thalamus and then to the somatosensory cortex, where the pain is perceived. From the cortex, descending inhibitory pathways comes down inhibitory pathways come down and causes reduction in pain. So this is a very simplified explanation of pain pathway. So I'm not going into the various receptors involved or the neurotransmitters involved. So if you're interested, I'll share a document later which will explain. So basically my point was, I'll come to that in the next slide. So this is just a basic pain pathway. So basically from the site of injury, the nociceptors will send the afferent signals to the spinal cord, and then it will be taken up through the ascending pathways to the thalamus and then to the somatosensory cortex, and then descending pathways come down, which actually inhibit the pain sensation. So the question I wanted to ask you is that, so suppose if there is a stimulus, a pain stimulus or like an injury or anything like that, the question I wanted to ask is, if the stimulus remains the same over time, what happens to the pain? Will it increase, or will it remain the same? So anybody in the chat can answer. So just
any response, either you can unmute or you can just type it in the chat. Yeah, there is one response: decrease.
Yeah.
Any other response? Or you want to?
Yeah, it will decrease.
Yeah, decrease. Yeah. Okay. So
there is one increase in
increase and all. So technically both answers are correct, but the truth is that except for in mild pain, in all other cases, if the stimulus remains the same over time, I mean, if we are not intervening, or if the injury or anything for that matter does not heal by itself, if the stimulus remains the same, the pain will increase. So that is what I wanted to discuss in detail with this pain pathway, and which will be a very important thing for our management and assessment of pain. Two concepts of recruitment and sensitization. So we'll just go back to the pain pathway. See, what happens here is, so as we all know, pain is basically initially, at least a way of telling us that there is something wrong. So whenever we hit any of our body part, we hit our leg to a wall, or put our hand in boiling water or something like that, the immediate response will be to pull back the hand, which will be happening in the level of the spinal cord. So basically pain is body's way of telling us that something is going wrong. So what happens if we cannot run away from the stimulus? For example, if we just hit our hand against a wall or something like that, or if we have an injury, if we just put our hand inside boiling water, we can just withdraw the hand. So what happens if that stimulus remains? For example, if a patient has a cancer which is not healing, which is actually progressing, that stimulus is present, what happens then? So body actually doesn't know that it cannot be taken away. So it actually keeps on telling you that there is something going wrong. For example, I'll just tell you an example. If you are staying in a house with a friend, so you are in another room, the friend is in another room watching TV. So you just call for your friend. He or she is not answering. So what do you usually do? So you'll just call louder. And if he's still not answering, you again will call louder. So there is something like that happening here. So initially, what happens is the body tells you that there is something wrong, and the body tell you that there is something wrong. It's still there. It is not going away. And unfortunately, we cannot run away from that stimulus. The body will tell you louder and louder and louder. So that is something called recruitment. So what happens is that these nociceptors who are initially stimulated by the pain stimulus will be there, and additional nociceptors will be recruited to perceive that stimuli and sends signal to the spinal cord. This process is called recruitment. So basically, to recruit is basically to get somebody else, right? Same thing here. So initial nociceptors who are actually associated with perceiving that pain stimulus will still be there. Additional nociceptors from the surrounding will be recruited to conduct the pain stimuli to the spinal cord. Another thing is called sensitization. Sensitization is, this recruitment happens, more and more nociceptors will come to that perceive that pain stimulus, and each of these nociceptors will be sensitized. That means that for the same stimulus, the electrical impulses that each nociceptor send to the spinal cord will increase. So they become more sensitive to pain. So that process is called sensitization. So basically what happens is more and more nociceptors will be recruited, and each nociceptors will be sending increased electrical impulses to the dorsal horn of the spinal cord, and that will result in increased perception of pain. So that is sensitization. So this happens at a peripheral level. So this is called peripheral. So what happens sometimes is when the signals keeps on coming, the dorsal horn sometimes gets overwhelmed or confused, and additional segments of the spinal cord are again recruited to feel or to conduct that pain stimulus. So that is called central recruitment, and they become more sensitized. It is called central sensitization. So one is happening in the peripheral nervous system and another is happening in the central nervous system. This can also happen in the brain. So more and more pain centers can get activated. The brain can become more sensitive to pain. So that happens in the central nervous system. So there can be peripheral sensitization and recruitment and central sensitization and recruitment. So this is one important thing that we have to keep in mind. When the stimulus cannot be modified, the pain stimulus cannot be modified, and the pain stimulus is not going to heal by itself, the same stimulus over time will result in increased amount of pain. So that is known as two important phenomena, recruitment and sensitization. So why am I talking about all these things? What is the importance? Anybody? So why are we learning about this? So how will it affect your clinical practice?
So that we can help them reduce the pain, which is not controllable by its own.
Exactly. So this actually brings us to the discussion of acute versus chronic pain. So basically, I'll just give you two scenarios. This is first is a 54-year-old gentleman. He's a known case of carcinoma lung with bone metastasis. He comes to you with a pathological fracture of the right humerus. Patient is grimacing in pain, has tachycardia, sweating. He says that he's in severe pain. So right when you see the patient, you know that he's in complete distress. The second patient, 60-year-old gentleman, he's also a case of carcinoma in the head of the pancreas. He's on chemotherapy for the past 4 months. Patient says that he is in severe pain, but he does not appear to be in distress. But he looks tired and gloomy and has decreased appetite and sleep. So which among these patients is telling you the truth? Who is actually having severe pain? The first patient or the second patient?
First patient.
Both of them. Yeah. So just wanted to tell you that. So both of them are having pain. So this is an important thing to keep in mind about chronic pain. So unlike acute pain, which is actually an acute response to an injury or any pathological thing, chronic pain behaves a little bit differently. So it has an ill-defined onset and prolonged fluctuating course. Overt pain behaviors like grimacing, sweating, tachycardia, and sympathetic hyperactivity are typically absent. Vegetative signs, lassitude, sleep disturbance, anorexia, etc. are present. Patients are usually they do not appear to be in pain in the traditional sense. The patient may not look like completely in distress, but they may be like very sedate, very gloomy, etc. But the only definitive way to determine the presence of pain is to obtain a verbal report from the patient. So our assessment in this kind of situations may often be wrong. So the only reliable way of assessing chronic pain would be to obtain a verbal report from the patient. So why I told you all these things is because just to convey this point, treat the pain early and treat the pain well. So as we have known, in palliative care, we often deal with chronic incurable diseases, which has a prolonged course. So we don't expect the primary stimulus, which is causing the pain, to go away in a day or week or even months. So it probably has a prolonged disease course. Various other factors are also contributing. So it is always important to address, so that if the pain is left unaddressed, it can actually go on for a long time. It can actually increase in severity because of recruitment and sensitization. And also treat the pain well. So if there is a continuous pain, you have to give analgesics round the clock. So not only should we address the pain, you also should treat it well. So again, one more thing to mention is that chronic pain, unlike acute pain, is not a symptom. It can be considered as a disease in itself, because acute pain often actually provides us with useful information, right? So whenever we hit our leg while running, so it provides us an information that there is something wrong. On the other hand, chronic pain in itself is a disease. It just goes on and goes on and goes on, and it doesn't have any useful physiological information and physiological role in the body, rather than causing distress and all those things. So it is always important to address the pain early and to address it well, so that it doesn't get worse over time. So having said that, so we'll just go to the classification of pain. So in a very basic sense, pain can be classified as either nociceptive and neuropathic. So nociceptive pain is usually associated with a tissue injury, and neuropathic pain with a nerve injury in any part of the nerve. So again, this nociceptive pain or tissue pain due to tissue injury can be divided into somatic and visceral. We'll come to that later. Second thing would be neuropathic, as I mentioned earlier. So again, neuropathic pain, as I mentioned earlier, it can be due to the involvement of nervous system, either peripheral nervous system or central nervous system. It can be either central or peripheral. So peripheral nervous system example would be most classical diabetic neuropathy or various other neuropathies, any infiltration of peripheral nerves by cancer, any neuropathies due to chemotherapy or various other treatments. Central neuropathic pain examples would be a post-stroke pain, for example, or trigeminal neuralgia can be considered as a central neuropathy, any cranial neuralgias, post-stroke pain, all those things can be central neuropathic pain. So neuropathic pain can be identified by basically by three things: the quality of pain, the distribution of pain, and abnormal sensation. The quality of pain, neuropathic pain is usually described as a burning pain or a pricking type of pain or a stabbing type of pain, radiating type of pain, electric shock-like sensation, etc. So you must all have had sciatica or back pain, back pain radiating to the legs at some point of your time. So you know how that feels, right? So basically, whenever a nerve is injured, it carries that pain sensation throughout the. So it can be radiating. The sensation may be different. Second would be distribution. Distribution is typically, if a particular nerve is affected, the pain is distributed over that particular nerve's distribution areas. Abnormal sensation is another important thing. There can be some paresthesias there. Two another important things, clinical signs that we can elicit is allodynia and hyperalgesia. So hyperalgesia is basically increased sensitivity to pain. Or normally less painful stimuli, the patient is actually perceiving it as a very painful stimuli. And allodynia is perception of a non-painful stimulus as a painful stimulus. So suppose if we touch the patient, he may actually perceive it as pain. Stroking the skin can be perceived as pain. Hyperalgesia is increased sensitivity to pain. So a small prick can be very excruciating for the patient. So all these things point towards neuropathic pain. So this is one type of pain. The second type of another important type of pain that usually is associated with neuropathic pain, which is very rare, but it can be an important thing just to know about it. It's like sympathetically mediated pain. So here what happens is there is an abnormal coupling between sympathetic efferent and nociceptive efferent neurons, which usually doesn't happen. So I'm not talking about the generalized sympathetic response to an acute pain. So this is about the sympathetic response to the body. So normally when there is a pain in a particular part of the body, we don't have sweating or redness or an increased temperature of that particular area, right? So that doesn't happen usually. But here, there is an abnormal coupling between sympathetic efferent and nociceptive efferent neurons. So basically, when there is pain in a particular area in the body, so there is associated sympathetic response to that particular area. So as with every neuropathic pain, there will be hyperesthesia or allodynia. Along with that, there will be sympathetic response like vasomotor symptoms. There may be a temperature asymmetry in that particular region. There can be skin color changes, skin color asymmetry, etc. And like pseudomotor changes like edema, sweating asymmetry, etc. So this is not a very common thing, but this is an important contributing factor of something known as complex regional pain syndrome, which is again very rare, but it is worth knowing about it. So this can also be classified under neuropathic pain because it primarily deals with the nervous system. Second thing would be the nociceptive pain. Nociceptive pain, as I again mentioned earlier, it is due to a tissue injury. So it can be either a soft tissue or a bone or viscera. So soft tissue and bone, we can classify under one group and viscera under other group. So basically when there is a soft tissue or a bone involvement, the pain is usually described as aching, throbbing and dull pain. Visceral pain, usually viscera, when there is any hollow viscous affected or any pain sensitive coverings like or visceral pleura, all those things are affected, then there is, it can be considered as a visceral pain. So that if a hollow viscous is affected, it is typically described as a colicky pain. Whenever, like the pain when we usually get when he has stomach upset or a urinary colic, etc. But if it is affecting the peritoneal coverings of organs, it may be a dull aching pain. So this is the classification of nociceptive pain. So basically, just to revise, in a broad sense, pain can be classified as either nociceptive or neuropathic. Nociceptive is due to tissue injury. Neuropathic is due to nerve injury, compression, infiltration, anything of that sort. So neuropathic pain can be either central or peripheral. Nociceptive pain can be either soft tissue or bone or viscera, which has a little bit of different sensations. So one important thing I wanted to mention about bone pain in specific is that usually bone pain has both an inflammatory and neuropathic component, because it is not, although we say that bone pain is a somatic pain or a nociceptive pain, it usually has a neuropathic component also. Because whenever there is a bone fracture or a bone metastasis due to cancer, there can be some direct nerve injury in that particular area, and there can be a consequential pathological sprouting of sensory and sympathetic nerve fibers. So bone pain, when established, especially in case of metastatic bone lesions, it always has a neuropathic component. Another important point I wanted to mention is that in a patient, in a clinical, pain is rarely in a box. It need not be either neuropathic or nociceptive. It often is a mixture of both. So we have to identify all these components and treat accordingly. So just keep in mind that although we classify pain accordingly, so many a times it can be a mixture of all these kind of pains. So as I mentioned earlier, visceral pain is either can be due to an obstruction of any hollow viscus or another pain sensitive visceral structures like visceral pleura, hepatic capsule or peritoneum. It can be of various reasons. Most commonly we see this like as it can be because of the disease, various diseases like cancer. It can also be treatment related, like after surgery, typically described as colicky twisting pain whenever there is an obstruction of hollow viscus. But if a pain sensitive visceral structure like pleura or peritoneum is involved, it may not be described as a colicky twisting pain. It may be a dull aching pain or even a pricking pain for that matter. This is visceral pain. So we have just completed the pathophysiology of pain and the classification of pain. Now we'll briefly discuss about the assessment of pain. So for assessment of pain, before going into that, so before we assess pain, it is always useful to keep the treatment in mind. So not only for pain, for all symptoms in palliative care, the three basic principles that correct the correctable, non-drug measures, and drugs for symptoms. So whenever a patient comes to you with pain, so you don't necessarily directly give all painkillers and send him back home. So we should always look for anything that is correctable. See, when a patient, for example, with cancer comes to you, so not all pains in patients with cancer are not to cancer itself. So it is said that even in advanced cancer, around 15% of the patients who are having pain, the pain is not due to cancer. Even in advanced cancer, 15% of the patients with pain, the reason for that pain is not cancer. There can be other things also. It can be a concurrent illness. It can be a debility. It can be a lot of things, an osteoarthritis or a diabetic neuropathy. It can be due to constipation or a pressure ulcer. All those things are there. So anything that is correctable, it is always important to correct. The second would be to try non-pharmacological measures, and third would be to give particular drugs for the symptoms. So the idea of assessment would be to find all the correctable reasons, to find what is going wrong so that we can give some non-pharmacological things or adjust the patient's lifestyle according to that. And finally, we can give for the symptoms also. So going to the next slide. So aims of pain assessment would be to find out the characteristics of pain, pathophysiology of pain, etiology of pain, and other factors contributing to the pain experience. So, so I just wanted, I'm not going to talk to you about detailed assessment of pain about how to communicate and how to assess and all those things. So just wanted to tell you 3 important things to keep in mind whenever you are dealing with the patients with pain. So the first thing would be to listen. So I'll just play a video clip from the founder of palliative care herself, Dame Cicely Saunders. Let us just listen to that clip.
I'm often asked, what is the first thing you really want to say? I'm often asked, what is the first thing you really want to say to somebody going into medicine or moving into palliative care? What is the major commitment? And I'm sure the answer is simply listen to your patients. They'll tell you. They'll tell you what they need. They'll tell you who they are and what they can achieve. I'm often asked, what is...
So the first thing would be to listen to your patients, because even if you don't ask any questions, if you are actually just listening to the patients, it will provide a lot of information. So just listen to the patients. So I remember, I've not been doing palliative care for long. I've only been doing it for the past 3 years. One of the first exercises that I was given when I came to palliative care was to see how long I can listen to a patient without interrupting. So it's actually quite hard. So I found that it was initially not more than 30 seconds. Then I am still working on increasing that time. So listening to the patient is actually a skill in itself. It will provide us with a lot of information and also give the patient a feeling that he or she is heard. That is very important in building the trust and getting a proper information regarding pain from the patient. The second thing would be to believe. So this is another saying from Dr. Robert Wycross, who is another pioneer in palliative care. Pain is what the patient says hurts. So as I mentioned earlier, pain is a very subjective experience. So two people with very similar diseases may have a very different kind of pain experience. So it is always important to believe the patient, what the patient says about the pain, and don't assume that what kind of pain or suffering the patient is going through. So another saying is that to assume is to make an ass of you and me. So don't do that. So we should never assume. So we should just believe what the patient says. At least in this context. So it is always important to believe the patient's complaint of pain. We need to have empathy and compassion. So if you don't in this assessment part, if you don't take home anything else, so just keep these 3 points in mind: listen, believe, and have empathy and compassion. So just having said that, keeping that in mind, then we'll just go to the various forms of assessment of pain. So as I mentioned earlier, the aim of assessment would be to assess the characteristics, pathophysiology, etiology, and various other factors contributing to pain. Assessing the characteristics of pain is very important, because then only we can actually give analgesics or whatever medicines to help with the patient's pain. So this is one mnemonic we usually use in assessment of pain. It is called the PQRST. P would be palliative factors and provocative factors, what increases the pain and what decreases the pain, and quality of pain, Q. R is radiation, whether it is spreading to anywhere else, severity and impact, and temporal factors. So palliative factors and provocating factors, obviously, palliative is just the relieving factors, what makes the pain better. Provocative factors, what makes the pain worse. Quality of pain. Quality of pain is very important in distinguishing the kinds of pain. As I mentioned earlier, neuropathic pain can be described as a stabbing kind of pain, burning, electric shock-like sensation, pins and needle sensation, all those things. Whereas visceral pain can be described as a colicky pain or a twisting pain. Somatic pain may be described as a dull aching pain, etc. So that will help us in determining the type of pain. The radiation, whether it is in a particular region or it is going to somewhere else, especially common with neuropathic pain, we can actually go to other areas as well. The severity and impact, which is very important because we prescribe analgesics or drugs for pain according to the severity. Another one is temporal factors. Temporal factors is basically relation of pain to the time. So when is the pain increasing? When is the pain increasing? Is there a sudden increase of pain in between? Or is it constant? Or is it come and goes? All those things will comprise the temporal factors. So all these are essential information for us to assess pain. So I'll just mention, because pain intensity or severity of pain assessment is very important, because that is how we prescribe analgesics. So I'll just briefly introduce certain tools that we usually use to assess pain intensity. So all these tools can be broadly classified as unidimensional tools and multidimensional tools. I'll just go to that. Unidimensional tool, one classical example is numeric pain rating scale. So whenever a patient comes to you, so you give them a scale from 0 to 10. So 0 is least pain and 10 will be the most. So you just ask the patient to give a particular number to her pain. So that's just a unidimensional. You are just asking about the intensity of pain. How severe is your pain? So all these new unidimensional scales are various forms of answering this question. How severe is your pain? This is one example. So numeric pain rating scale. So if a patient says that her pain is 5, it is a moderate pain. 7, 8, 9, 10 are severe pain. So each visit you can actually ask the patient again this thing, and you can assess whether the pain is going up or remaining constant or going down. This is numeric pain rating scale. This is another visual analog scale. This is a continuous line. So the patient is asked to make a mark in this line according to the severity of the pain. Towards this side will be more severe. Towards the left-hand side would be less severe. Another thing would be Wong-Baker-Facer scale, where the pain, it was initially used for children. Now it is being widely used. So you actually see the patient's response to pain and then assess the pain accordingly. So all these things are basically unidimensional scale. You're only asking the question, how severe is the pain? Various forms of answering. So the next step would be the multi-dimensional scale. One example would be McGill Pain Questionnaire, which came to existence in 1975. So here we are not only asking about the severity of the pain, we are asking about the site of pain, the quality of pain, how the pain is affecting the day-to-day activities, etc. So this is actually a little bit more comprehensive and hence dimensional scales. Another example would be brief pain inventory, similar to McGill Pain Questionnaire, another multidimensional questionnaire. So this is, I'm not going to these pain scales in detail, just to let you know that there are various ways of assessing pain, which are which can be recordable and which are objective, not objective assessment of pain. Objective at least as far as physician is concerned, so that we can actually, another person can actually see this and assess the pain. So it is not possible to use multidimensional pain scores for every patient because it is extensive and difficult to convey and difficult for the patient to fill also. But again, these are useful in certain scenarios. But just keep in mind that there are various ways of assessing pain. They can be multidimensional and they can be unidimensional. So another important thing I just wanted to introduce is MCC and distress thermometer. So as we mentioned earlier, pain is not only a sensation, but it is an emotional experience. So it can actually be an important cause of distress for the patient. So here what happens is we can actually assess the distress of the patient. So again, this is like a thermometer and it has scoring from 1 to 10. So basically we are asking the patient about how distressed they are, and then we go into the causes of distress. So this is another tool that we can use for assessing pain. So temporal, as I mentioned again, is the time relation of the pain. So one important factor I wanted to mention is something called breakthrough pain, especially in chronic pain. So there are basically two components of pain. A pain which is present throughout the day, which is a baseline pain with intermittent spikes in between. So these spikes are called breakthrough pain. So this is a background pain which is present throughout in between the breakthrough pain. So always, whenever you ask for pain or assess for pain or treat for pain, it is always important to consider these two things. We have to give something for the background pain which is present throughout the day, and we have to give SOS doses of analgesics in between to cover for the breakthrough pain. So just wanted to tell you that point. So having said all this, the question to address is, do we underestimate pain? So the answer would be yes. So there are various studies showing that, for example, a study by Grossman et al. Shows that when patients rate their pain as moderate to severe, oncology fellows fail to appreciate severity in 73% of the cases. So nothing towards oncology fellows, just a study, that's all. So we all do underestimate pain. Another study, ECOG study, shows that discrepancy between patient and physician evaluation of severity is a major factor in inadequate relief. So this is not only related to other specialties. See, this is another study which was conducted in the hospice, in an end-of-life care, where the primary aim of the physicians there was to make the patient as comfortable as possible. So this happens even in palliative care. So they have found out that in this scenario, pain was underestimated in 46% of the patients, whereas it was only overestimated in 28% of the patients. This underestimation was clinically and statistically significant. So this happens all the way. So we do underestimate pain. So coming back to the previous points, all these things basically comes because we take judgments. So we don't actually ask the patient how severe is the pain. So even when the patient says something, so we consider our judgment superior. So we must have seen thousands of cases or hundreds of cases of similar diseases, and we have a picture of in our minds that this much of disease will cause this much of pain. So we assume and we underestimate the pain. So we don't let that happen. We should not let that happen. So always keep in mind that self-report is the best report. And again, last point I wanted to mention is use help. See, as I mentioned earlier, pain is not a single dimensional phenomenon. As we mentioned earlier, so the concept of total pain says that there is social, emotional, spiritual, all sorts of aspects of the pain. So in at least some of these things, social worker or a psychologist will be better equipped to assess that particular part of the pain rather than a medical professional or a doctor. So always use help. So this is not something that we can deal alone. So whenever help is available, please always use that. So with that, I'll just conclude my session. I hope that it was not very painful. So I think we have time for some questions if there are any.
Thank you, Dr. Jewell, for touching upon all the important aspects for an introductory session to pain. We have some time to take up a few questions. So if anyone wants to ask question or comment, please unmute and speak.
Hi, Dr. Jewell. This is Dr. Satyajit from AIIMS Bhubaneswar.
Hi, sir.
Yeah, thanks for a very lucid talk, and you've made a difficult topic seem very easy. I just had a query in my mind.
Sure, sir.
Is there any difference? I mean, if you're looking at the unidimensional scales of assessment versus the other ones, that questionnaire-based scales of assessment, is there any difference in the way you prescribe treatment to the patients, or is it just for our own understanding?
So mostly it is for our own understanding, sir, because the only idea would be if we get some additional insights from using the multidimensional questionnaire. So but the main phases, we may not be able to use that scale in all the patients. So currently we basically use those for like study purposes, or when we really need to know the cause of patient's distress. So especially in patients with advanced cancer and a prolonged disease course, we may be confused between an existential distress or a physical distress. In such conditions, using a multidimensional scale may throw some light to the cause of patient's distress. So otherwise, in our routine clinical practice, I basically use only the numerical pain rating scale along with the routine questions that we ask. So yeah, as treatment is concerned, it is mostly unidimensional pain scoring, sir. But in certain criteria, the other may be used.
Thank you.
Any other questions?
Good afternoon, sir.
Good afternoon. Good afternoon.
Dr. Neha here. Sir, I just wanted to know, okay, according to unidirectional pain scale, we can rate it into difficult pain, like if the severity is extreme. So that will be on that scale level only, that will be considered as a difficult pain or severe pain, right? Or like we can totally rely on it, right?
Yeah, because basically it is a way of asking the patient, right? So it is a way of patient reporting. So as long as pain is concerned, the primary thing, the most important way to assess pain would be to ask the patient to say how severe it is. So I mean, it is important that the patient understand what it is. So even for some patients, this numerical scale may be confusing. So if you, the idea of numerical pain rating scale is during the reviews, it will be very easy to compare the pain scores if the patient gets that. So it is some even anybody can assess because there is something objective there.
Okay, thank you, sir.
Thank you, Dr. Jewell. Just adding on to that one point, as he mentioned, it's easier for review. Otherwise, what we write, the patient had severe pain. Now the pain decreased. So decrease when you write, for me, it might be 1 out of 10, and for the patient might have thought about 6 out of 10 from 10 by 10. So we really don't know whether to increase the analgesics or you need to assess more for a neuropathic pain. So it's very I mean, sometimes it's very confusing for the patients, but if you use some local methods which they can understand, that is something that you really need to document on your case sheet so that when the other doctor comes, or for your own sake, you'll understand where exactly your medication stands, or you want to review your medications at some point of time. There are two hands raised. Dr. Nishant. Nishant, you had
So
a...
this is Dr. Ishan.
Hi.
Hello.
Hi.
Am I audible?
Yeah, yes. Please, Dr. Nishant.
Sir, so this question is regarding radiation. Sir. So when we encounter complaints with respect to mucositis associated pain in head and neck cancer, sir, we give, so your statement was that if stimulus remains the same, the pain should decrease over time. So when it is associated with the mucositis, so the pain that the increasing sensation of pain, when the patient complains of increasing pain on a daily basis, sir. So is that due to recruitment of new nerve fibers because the daily dose of radiation is the same, or is it due to the cumulative effect of radiation building up over 5 weeks or 6 weeks or 7 weeks?
You're asking about radiation mucositis, right?
Yeah.
So
Yes, sir. Yes, sir.
I was not able to completely hear you, but I'll just tell you what I understood. So you're asking about radiation mucositis, and even after radiation and even after the mucositis is settled, the patient is complaining of pain. Is it what that you are telling?
No, sir. No, sir.
During radiation.
What I asked during treatment, sir, when you say that if stimulus remains the same, the pain should decrease. So when you are giving the daily fractions of same size, how does the pain sensation keep on increasing? And is it due to the recruitment, or is it due to the inflammatory causes that have built up over the period of treatment?
Yeah, the most important cause I think would be the cumulative effect of radiation, because you are giving daily fractions. There is no more mucosal damage. So in that case, obviously we can, in many cases of radiation of our head and neck, we can see that the mucositis or dermatitis increase over time. So many a times during the course of radiation, so in that case, there is an increasing stimulus that we can see. So although there is the cancer may be decreasing, the inflammatory effect of radiation, the mucositis and all those things can be increased because of the cumulative effect. There may be some recruitment, but the primary primary reason in that case would be the cumulative effect of radiation. And very often we can see that whenever the radiation is stopped and once the mucositis settles, the pain obviously will come down. So that means that is primarily related to the stimulus. When the stimulus is more and the mucositis is more, the pain is more. And when the mucositis settles, the pain decreases usually. So that is usually associated with the directly proportional to the stimulus. There may be some recruitment, but the primary cause would be the cumulative effect of radiation.
Dr. Srikanth?
Hello, Dr. Joseph. Am I audible?
Yes, Dr. Srikanth, please.
Yeah, thanks for your detailed presentation. I have two questions.
Please.
The first is when you mentioned the rating of pain with the facial expression scale, I was given to assume that it is a Likert scale which we ask the patient to rate how the pain is, or do we look at the expression and then put a score? You
are talking about the Wong-Baker's FACES scale, right, sir? That is a physician's assessment. So we see the face of the patient, and then it was actually primarily developed for children who cannot actually communicate for pain, which then over time has grown. I mean, it has been currently being used widely in all age groups. So the idea would be we'll see the face and decide how much pain the patient is in. That is the idea.
But then that for as some of the scenarios that you mentioned, for chronic pain, that may not be entirely.
Definitely. So I was not just introducing various tools to assess. So what we please continue.
So could we then use it? I mean, of course, the Wong-Baker scale, then we cannot use it for the patient to then mark how the pain is going to look like.
You want the patient to mark it actually?
Yeah, because they might be showing some expression, but internally they might be feeling something else, because as we use Likert scales.
Yeah, in that case, I think numerical pain rating scale or a linear scale. So these are just various tools, but personally, in my practice, I usually use the numerical pain rating scale because it's very quick and very easy to just write it down, because the pain score is 5. So otherwise, the FACES scale is difficult to use. These are just because at least in some conditions where the patient cannot communicate properly, or in pediatric cases, this may be useful. So it is not a foolproof scale, but yes, obviously in chronic pain, you cannot assess the patient's pain with the facial expressions alone. Then we'll need a verbal report.
So I have one more question. In the assessment of pain, in recent advances, are we looking at tools such as near-infrared spectroscopy, and tools which might become accessible in the near future, in the next 5 to 10 years? Yes, because I've seen some literature where they have started using NIRS for pain assessment, especially in the activity in the dorsolateral prefrontal cortices. Any thoughts on that?
So currently we are, especially in palliative care, we are not using that. And so I personally don't know how it will affect our treatment. So when you go to the management of pain, you will know about the WHO pain ladder. So what we basically do is we'll differentiate the pain and we'll score the pain. According to the severity, we will try the drugs. Knowing the pathophysiology of pain or the activity in the brain and all sorts of things will help us know more about the pain phenomenon itself. But as far as palliative care is concerned, we are primarily aiming at the symptomatic relief for the patient. So as long as it doesn't provide anything extra on how we treat the pain. So I don't think currently we are anywhere in palliative care it is being used. That is my understanding. Sridevi ma'am, please correct me if I am wrong.
Yeah, same here. I think we are focusing more on the patient's experience of pain and believing what he is going through. So, for example, we hear it routinely that doctor said everything is fine after seeing the MRI, but I'm still in pain. But doctors keep saying that, but everything is fine in an MRI. Doesn't look like, there is some pain stimulus, but the patient is like in terrible whole body pain. So there is no real scientific explanation as per the doctors for having this pain. So where do you stand? Where you want to rely on that in particular investigation and then treat pain, or you want to believe that the patient is telling you I'm in pain? So I think that's where I have my own reservations on that, because many times this is a thing that we hear, like, especially when it comes to non-cancer. You don't have cancer, or your MRI looks fine, your PET scan looks fine, or this investigation looks fine. So there is no treatment, but the patient is in terrible pain. So that's I think this should come in the palliative care community. Even if this kind of developments come, I think there will be slight reservations on that. Thank you.
Just to add to that, we mentioned about the total pain there. So primarily, as Madam told, we are treating the pain experience, and the pain of the patient cannot, in many cases, may not be. We cannot explain it scientifically. So there may not be a scientific or identifiable explanation to patient pains, or maybe many other factors. So that we usually focus more on the experience and of the person rather than the actual pathology of pain. It is important, but again, for treatment purpose.
Thank you.
There are two comments or questions in the chat. One is about the multidimensional pain scales. Can it be used in an Indian context?
Yeah, it can be, but again, it should be translated to that local languages, and it has to be conveyed to the patient in a local, the appropriate way, rather than making it more complex. So one of the most problematic issues with the multidimensional pain is its complexity. The patient may not be able to use that. So if you can convey that ideas to the patient in a language that they can understand, can very well use. The challenges would be to convey those things to the patient in a language that they can understand.
And the next question, do these assessment scales mostly take only the physical component of pain into consideration and not the other components?
Yeah, that unidimensional scale is actually asking the patient how severe is the pain. So that is basically asking the patient how is her pain experience. So it may not be just, we are not asking about the sensation. We are just asking about how are you feeling, how severe is your pain. So that probably will include all sorts of pain, because when the patient says that he or she is in pain, that will include all the components of total pain. So we are not primarily focusing on the physical as such, although we are asking about the sensation. And multidimensional questionnaire will usually branch into how those affect your sleep and all those things. So it will be a more comprehensive coverage. But even when we are asking how severe is your pain, it is not limited to the physical thing, because we are asking the patient about his or her experience. That will automatically include all those factors which are affecting the pain.
Dr. Shweta, you have a question.
Good evening.
Good evening.
Sir, I wanted to know if there is any specific time interval for reassessment of pain and how medications, how often should they be changed depending on the response?
Yeah, that I think you will be taught about in management of pain. As a general thing, we usually say. So basically that will depend on the half-life of the drug and how long it will take the drug to maintain a stable plasma level and get the desired effect. And in severe pain, we'll reassess much more quickly if the patient is in severe pain. So that will depend on various factors. So the type of drug that you are prescribing, the type of pain that the patient is having, how severe the pain is, all those things will come.
Oh,
so
not from the drug point of view, sir, from the patient's perception point of view. Is there any?
Unless we are intervening, I don't think how, why do we review the patient? Why do we review the pain? Because we only review the patient to know whether the pain is getting better or not, right? So if we are not intervening, so I don't think how that will be relevant to review the pain again. So we don't, once again, we don't actually need to wait for the pain to become significant to a significant level to start treatment. So the whole point is to treat the pain early. So if a patient says that he is in pain, so I don't personally see any reason to just let them go and make them come after 2 or 3 days to reassess the pain, unless we are doing something.
Oh, no, can I just be a little more
clear?
Please, I was say, for example, if we assess today and we start put the patient on medications, then say for a week or 10 days, the patient is doing fine, but it's not entirely, maybe not entirely controlled, but still considerably manageable. So within those 10 days frame, will we modify the medication schedule or wait, continue with the same regimen for about 15 days or 20 days and then reassess based on the patient perception and modify the medicines?
Okay, so I got your question. So you are, see, the thing is, you mentioned about the 10 or 15 days, right? So that period that we give the drug for will depend on all these things that I mentioned. So it will depend on the type of drug we are giving, the severity of the pain the patient is having, and the time that the drug will take to attain a steady state plasma concentration. So if the pain is very severe, if you give some drug in the night, you will reassess in the morning because the patient is in severe distress. So if the pain is mild, you can actually take 3 days or 4 days just to wait for the drug to act completely, I mean, in the sense to get into a steady state plasma level. So that will, it is difficult to give a single answer to that. But that will depend on various other factors. In a general sense, we can say that 48 to 72 hours, but again, that will be very variable. Thank you.
So there are a few more questions in the chat. Dr. Rashmi is asking any comment on the gate control theory of pain. We are touching upon that in the coming session. If that is fine, we'll take the second question. Which assessment can we rely on if the pain is subjective? If the pain is, I am not really clear about that question. I think even if the pain is subjective, pain is definitely subjective. And yes, and that we rely on the same assessment methods, I guess. So Dr. Aditi is asking, how do we assess the pain if the patient is unresponsive?
So, see, there are certain pain assessment tools to assess distress, especially in ICU setup when the patient is actually unresponsive. So basically you monitor the vitals and all those things. So the problem with assessing the pain in a patient who is unresponsive is that you don't know actually the cause of distress in such cases. So exact assessment of pain would be difficult, but there are certain scores where you monitor the vitals and all those things, and the blood pressure, the heart rate, respiratory rate, and all those things, and assess the distress of the patient rather than pain alone, because it is difficult to pinpoint to pain when the patient is unresponsive. But that doesn't matter actually. When the patient is in distress, you can assess that and treat accordingly. But how efficiently you can assess pain in a patient who is completely unresponsive, there are certain tools to assess the distress or comfort of the patient when unresponsive. Ma'am, anything to add to that, ma'am? Sridevi, ma'am?
Maybe in a simpler way, as you told, we assess mostly the distress part of it. And usually their facial expression, there will be grimacing. And you ask the caregiver while changing the position or cleaning, whether they are showing making some noises. Very commonly they make noises, or their face changes, they grimacing and wrinkles on the forehead. And then you just try one dose of pain medication, and then you see whether there is a difference. If there is a significant difference, then we assume that it was because of pain. That's how we go about in a home care setting, or in a very, very practical setting. That's how we go about it.
True, true.
Because many times we may not be able to do this proper assessment when the patients are not in a hospital. So this is how we ask the caregiver over the phone. Many times now it's telehealth and stuff. So we ask them whether they are making some noise or showing some discomfort while you change the clothes. Then they will understand and they can tell you in a clear way. Next question, Dr. Chaitanya is asking about your thoughts on placebos and pain relief.
So, to be honest, we never prescribe placebos to a patient who says that he or she. So, as I mentioned, I mean, unless it is done as part of a study, and I don't think there will be any study in palliative care when some patients with pain will be given placebos, and some that is totally unethical. So, out and out unethical. So that won't happen actually. So in palliative care, if a patient says that he or she is in pain, we always prescribe analgesics or any medication to help the pain. So I don't think, I don't think that there will never be a study. There will never be a study in palliative care where placebo is tried against analgesics. So, maybe in some other diseases or conditions, some chronic pain or something like that, but not in palliative care.
Yeah, the same question was asked by another participant on a personal chat. But ma'am, when I gave placebo, his pain got relieved. So I told son, then there must be something that you are conveying, that you are conveying that I believe your pain and I'm giving some medication, right? So he might have gone to different doctors who haven't even given up medication or haven't even heard. So you might have heard, you sat there, you might have conveyed that, okay, I can give something. You've shown some interest to treat this patient. That might be the reason why the patient got some relief. It's not because that you are giving a placebo. And I totally agree with Dr. Jewell. I don't think in any future we might be giving placebo in palliative care, because what we preach is to believe the patient when they say it hurts. It's the hardest part of learning pain management. To believe, especially in chronic pain, the patient, we often hear comments like he doesn't look like in pain, but it's all about believing them when they are in pain, and that makes a huge change in their lives.
That is the importance of being empathetic and compassionate, because rather than the placebo, your empathy and compassion must have made the pain better. So yeah, so that somebody is willing to hear and somebody is willing to address that, believe that there is pain. That makes a difference in many cases.
Thank you. So if there are no other questions, we can take up more questions maybe after the case presentation again.
Sure.
So shall we start the case presentation? Dr. Ariba, are you there?
Yes, ma'am.
Please.
Ma'am, am I audible?
Yes, you are.
Okay. Good evening, everyone. I'm Dr. Ariba, and I'm working as a junior resident in Pain and Palliative Care, SCIMS, Kashmir. My patient, 49 years old male, who was diagnosed case of CA prostate, stage 4. Presented with a urinary obstruction, insomnia, severe back pain, which was radiating towards both of his lower limbs. History of illness. He was a known case of advanced stage prostate cancer, grade 4, who is on palliative targeted therapy and is now presenting with the complaints of back pain radiating towards both lower limbs. That's actually disturbing his sleep along with urinary obstruction. He was normotensive and normoglycemic. He was smoker and non-alcoholic. On examination, his vitals were normal. He was moderately built and nourished. He was having tenderness in the lower dorsal spine. CVS respiratory system showed no signs of abnormality. Abdomen, he was having normal bowel sounds. Abdomen was soft but was tender. External genitalia showed no signs of any deformity or anything. CNS, he was conscious oriented. During his treatment and investigation, his recent CT scan showed focal signs of CLD with dilated postosplenic axis. Bone window reveals diffusely distributed blastic lesions in axial appendicular system. Prostate was a size of 4 into 4.5 centimeters. Bone scan showed abnormal radiotrace uptake in involving skeletal sites, sternum, bilateral humerus, bilateral scapula, multiple ribs, multiple dorsolimb vertebrae, bilateral pelvic bone, bilateral femur. PSA was 69.80 nanograms per ml. Testosterone levels were 40.32 nanograms per deciliter. Creatinine level was 2.1. The patient was on chemo drugs, but it does not work. Then he was shifted to cabazitaxel. Patient is planned to undergo palliative radiotherapy. Patient is receiving morphine 20 mg 4 hourly along with injection zoledronate monthly. Psychosocial aspect, he belongs to lower middle class. His wife is not working. He has 3 children. 2 of them are pursuing their studies. He's a laborer. He's the sole bread earner of the family. He's strong enough to understand the diagnosis, treatment, and its consequences and prognosis. He's taking the treatment under Ayushman Bharat scheme. Medication, he was taking tramadol plus paracetamol combination initially, which worked for 2 weeks. But then he was shifted to paracetamol plus codeine combination later, which worked for a month. But now he presented again with the pain and he was given 20 mg morphine 4 hourly plus adjuvant therapy, nortriptyline 10 mg BT. Bedtime because he was having insomnia. He was also given multivitamins and antioxidant once daily. Injections zoledronate monthly. For urinary obstruction, urinary catheter was placed and palliative targeted therapy with cabazitaxel. Patient's main concern were patient is having neuropathic pain as he presented with back pain and radiating towards both of his limbs. Psychological stress for the patient and his family in dealing with the progressive nature of the disease and prognosis. Disease is progressing in spite of the treatment. Prognosis is bad. Survival is poor considering the progressive nature of disease with multiple metastatic lesions and local disease progression. Economic difficulties with continuing treatment. The summary is a 49-year-old male patient diagnosed with stage 4 prostatic cancer with multiple bone metastasis under palliative treatment is now showing signs of disease progression, both local and systemic. The discussion points. According to patient, concerning the patient, coping up with the progressive disease and pain, coping with the prognosis, coping with anxiety and insomnia, economical aspects of continuing the treatment, future of his family, acceptance of his inevitable death, possibly within a year, and the concerns about his the concern that his family has are coping with the prognosis, emotional and psychological aspects of dealing with the loss of their family head in the near future, economical aspects of dealing with the cost of the treatment, education of the children and family expenses. Thank you, everyone.
Thank you, Dr. Ariba, for the presentation. I just want to convey that this last slide on discussion points, this essentially has conveyed about the concept of total pain that we have been discussing. It is the experience not just for the patient. So it's not just a pain due to the metastasis or the illness per se, but pain due to the coping and the prognosis and the anxiety, and along with the pain that the family is undergoing. I think that covers the entire concept of total pain, and I'm glad that you could catch up all this information while you are assessing your patient. So thank you so much for bringing this up. And I would like to ask the other participants before we ask Dr. Jewell, like, how do you think should we manage these kind of situations? Now we have come across with a total pain scenario. So how do we deal with these issues one by one? So it's not just his pain due to the metastasis that we are talking about here, but the whole pain. Anyone can unmute and comment, or you can type it in the chat.
Madam, if I may.
Yes, please.
So, ma'am, in the beginning of the case presentation, we saw that the wife is not working. So, and the concern of the family, since they're coming from the lower socioeconomic status, the economical aspect of the pain will have to consider, ma'am. So, the first and the foremost thing is to be for us to explain the poor prognosis of the patient. The family has to come to terms with it, and alongside that, we'll during the same process, we'll have to make the wife incline the wife towards taking up some kind of a vocational training or a job that would probably take care of the family expenses and economic requirements.
Thank you, Dr. Nishant. Yes, a very valid point. It's about empowering the family as well as the patient. So before he has to go through the end of life situation, he might be assured that my family is kind of taken care of, or they have some means of going ahead with their lives is very, very important. Thank you so much for your feedback. Any other? Yeah, so there is a chat, Dr. Ravi Kiran. So the main distressing factor is physical symptoms is pain and not able to do his ADLs and being dependent on others. And he's also the breadwinner, without which their financial income will be meager, which will make him anxious and apprehensive of what will happen to them. Very true. Like very similar to Dr. Nishant was mentioning, it's all about losing the breadwinner as well as the loved one. So they have to cope through the loss of loved one as well as the loss of income. That's something that we need to deal with. Dr. Neha, you had any comments, please?
Yes, good afternoon, ma'am. Actually, there is one of the point, acceptance of his inevitable death, possibly within a year, and future of his family. So short-term, according to me, short-term targets can be made for the patient and the family, like what he wants to achieve in that period of time. That can be helped by palliative group of personals. Like in 1 month I have to do this, so emotional targets can be achieved. Like one of my patient was going for palliative chemo, and he also had his daughter's marriage. So we thought as a human to first go for his daughter's marriage, then for palliative chemo, as he had his own side effects for them. So that short-term goals can be made, as far as I think. Thank you.
Excellent point, Dr. Neha. Very, very, very good point. That's very true. And after all, it's for the patient that we are all working for. So the goals has to be set by the patient, not by us in terms of treatment. A very valid point. Dr. Shetty?
Yes, I'm Dr. Shetty from Kolkata. Just here, I just want to mention we were talking about part of pain only, because it's a continuous process. We cannot see the patient and prescribe the medicine and go. Here, I'm missing something about the teamwork. when you think about the emotional and psychological, even economical aspects, I don't think one doctor can alone manage the rest of the things. So you definitely need a social worker or counselor or along with you. Don't you think so? So that continuous service should be there.
Exactly, ma'am. Exactly. Very valid point. And it need not be. I mean, obviously, as you mentioned, a doctor cannot do this alone. And it should not be. It should not be. I mean, if as I mentioned, whenever there is help available, so by all means, we should take it.
Yes.
So definitely. Very, very valid point, ma'am. Very valid.
And I will come to know, like, your class was also quite encouraging. And one more thing I just wanted to discuss earlier, because that pain, when you're discussing about the pain, I have one patient with glioma, that glioblastoma. And the main problem, he is not able to express, but even now and then he cries. And his family is also not there, some divorce case. And there I couldn't manage with that. I know he doesn't need any painkiller, but how I will be able to manage that patient?
Exactly. He is not able to express what he is trying to convey.
No, because he's already paralyzed. Only thing when he's crying a lot in between.
Yeah, so
but he is responding. Like if I ask something, no, he wants to say something, but he is not able to.
So you feel that the fact that he is not able to express is making him more distressed than the pain itself.
Yes, yes.
So, ma'am, again, see, I'm not able to give a straight cut answer to that. So probably
definitely
we may actually try to for example, so we had a patient, I mean, same a glioblastoma patient. So who always, whenever we go for rounds, he always used to do something with his face and finally ended up crying. So what we used to do is we actually repeatedly kept on asking him various questions. So if he just moves that, does it hurt? What do you want to see? So is it that? Is it that? So keeping on talking to him actually helped after some time. But again, see, this is a very difficult situation. So I basically don't know what is actually troubling him. So
I know. The main reason when we go for home visits, sir. So we cannot go very often. No, it's exactly, a Kolkata is a big place. So once in a while you can go and come. But I am keeping touch with the patient party. But only thing, when there's certain things, we cannot tell. I cannot start morphine or what without confirming the diagnosis. How can we treat the painkiller? How can give the painkiller?
Yes, ma'am. The patient I mentioned, I mean, since you mentioned, I remembered. So he actually liked someone sitting near him and holding his hand, just hearing out what he is telling.
Definitely.
So initially what happened was we'll just sit there for some time and then we won't understand what he is trying to express. We'll just leave. So he'll be like totally in distress. So at later point of time, we try to sit with him, just hold his hand. So although we don't understand anything, we just sit there, we just be there and just respond to what he was trying to convey. So probably he knows that we don't understand anything and we don't understand anything either, but I think that actually helped. So in many situations, being there for him and just letting him know that he's being heard and he's being cared will make a difference. But again, as you told, I mean, it is a very
as a doctor giving the treatment, that is that question arises, what to do. Understood. So that's in general, we are all facing the problem.
Understood. But I mean, since you feel that it is not exactly because of pain, distress is more due to the way that he cannot express. So I cannot think of any treatment that is particularly will be helpful. So it will be like involving a psychologist and social worker.
Definitely.
That will be more beneficial. So unless there is something that we can treat. So treatment in the traditional sense, I think, I don't know how much it will work here.
Yeah,
sure. I get your point, ma'am. But again, to be honest, I don't know. I don't know what treatment to
No, just like I just discussed one of my cases. Good.
Exactly.
I know. Like, okay, thanks.
Thank you for bringing it up.
Yeah,
thank you.
Thank you. Dr. Anuba.
Hello. Dr. Shetty actually covered some bit of it. I actually wanted to talk about the emotional side of managing. A lot of times patient needs support and the support can come from support groups also. And connecting with a non-profit organization, or an organization which is working from that end. I felt that this part is not covered. Also, a lot of times there's a lot of anxiety revolving around in such scenarios. So understanding if they're going through any psychological issues or personal crisis, and probably connecting with them with the psychologist there and then could also be a helpful factor, I feel. That's what I wanted to add.
Very valid point, Dr. Anuba. Thank you.
Yeah, also, sir, your presentation was really well. And after ages, I heard somebody talking about CRPS. I just wanted to mention that I'm a dentist, but I also live with CRPS myself.
Okay.
So, yeah, thank you for your presentation.
Thank you, Dr. Anuba. Thank you.
Thank you, Dr. Anuba, for sharing your personal experience with the group. Yeah. Dr. Srikanth?
Yeah, I mean, the presentation was really comprehensive. All points were touched upon. Thanks for that. Just a few comments on the it's good to have information on the severity of pain with scales with NRS and how it was managed, probably if it was severe pain to begin with, and then the dosing of morphine was escalated based on that, and whether the pain was controlled based on the NRS or quantifiable scales. So that was one point I wanted to make. Another thing was whether any information was available on the motor aspect, motor examination, mobility related aspects, whether the patient was able to walk, was the pain interfering with ambulation, whether braces were needed or not. Sometimes a TLSO or a Knight's brace would help in such patients. So just these two small points that I can think of right now.
Definitely. Thank you, Dr. Srikanth. The adjustment of dosing of medications according to the severity of pain scale and the review will definitely be covered in the later sessions, I think. I'm sure. And regarding that braces and mobility, that's a very valid point. So this mobility thing and physiotherapy especially is important in patients. The patient here who has multiple vertebral metastasis, and if he's walking around a TK, a tailor-made brace would definitely help, or any other brace for that matter, I mean, whichever is appropriate. The second thing would be this mobility I just wanted to mention, because especially in patients, I have seen in patients with carcinoma breast, when they undergo palliative, post-operative radiation and all, they will have some difficulty in mobilizing the shoulder. In such cases, yeah, this mobility will definitely help. So a pain scale and the dosing accordingly definitely will be covered in the next coming sessions. Thank you, Dr. Srikanth.
Thank you, Dr. Ravi Kiran, also for the comment on how to manage every aspect of the pain, how to take help from the MSWs, how to support the family, how to what is the role of psycho-oncologist during this journey. And thank you for that comment. And Dr. Shweta has mentioned about it's important that the family understands what the patient is going through, what the situation is, so that they can plan the future needs and that can be addressed through counseling. Yes, that preparedness is very important. As it is mentioned, acceptance of the inevitable death possibly within a year. And they'll be so anxious about the physical symptoms per se. It's not death as such. People are really worried about whether I'm going to die in pain, whether I'm going to be breathless. So these are the issues that they generally discuss. They're all worried about the symptoms when they are dying. So it's very important to have those discussions beforehand. Thank you, Dr. Shweta, for that point. I think, Dr. Ariba, some of your questions were answered. As I think from the discussion, what we understand is that it's the role of multidisciplinary team, because you have brought in all the aspects of pain. So sometimes when you are alone, you may be able to cover a little bit of it, but then you need the support from your, the social workers or the psychologists or the counselors, where they have more ability to deal with, or they're trained to deal with these kind of situations. And even the social aspects of it. Here in Kerala, we rely mostly on volunteers to follow them up, whether they are coping really well. And I don't know whether you all remember about the palliative care, the pattern of palliative care, where we continue support as the bereavement care even after the patient is no more. So that's some kind of assurance that we give the patient, that we are going to be with your family till they are on their feet again. So we are going to be there with the family. That kinds of gives some support, so that they know that there is someone to call and ask whether they're coping really well. And we do that also. It's not just giving a word, but we do bereavement support and assess whether what more they need and what can be done. and making sure that they are coping really well.
Yes, definitely. Thank you.
Thank you, Dr. Ariba. Are there any other questions before we have 5 more minutes? If you have any pressing questions to Dr. Jewell.
Ma'am, I just wanted to mention one thing, ma'am. So doctor, regarding that treatment, the drugs that she is currently on. So initial thing, I just wanted to mention, I mean, this may also be helpful in decreasing the patient's distress. So I see that the adjuvant that was given in the beginning was nortriptyline, and the patient had urinary retention to begin with. So in such cases, I think it is better to avoid drugs with antimuscarinic actions. But now that she is catheterized, that may be okay. But again, whenever there is some urinary retention, better to avoid drugs which has antimuscarinic action. And second thing would be the patient currently is on morphine 20 milligram fourth hourly. So always, always important to give PRN doses also, because there may be some breakthrough pain. And paracetamol definitely can be considered. I mean, continued along with morphine. So it's not like once morphine is start, that should be stopped. And if this radiating pain is new, so it is worth looking whether there is any spinal cord compression or nerve compression caused by this disease. In such case, palliative radiotherapy will definitely help. And if there is some nerve compression or cord compression, a dose of dexamethasone, at least a trial of dexamethasone would be definitely worth doing in this patient, because it may, if there is some tumor edema and compression, it will drastically decrease the pain, at least for some time. So it may not be a permanent solution, but at least for some time that may be worth trying. So adjuvants, we usually use in our setting is called mirtazapine. It is not a first-line drug which is usually recommended, but we have found that it generally improves the mood. It is not very toxic. It doesn't have antimuscarinic side effects. So it improves sleep as well. So I think especially when there is urinary retention, TCA is better to be avoided, and other drugs can be considered. Even pregabalin can be considered. Nortriptyline is not a bad drug, but in this scenario. That's all I wanted to add. Other things, I mean, your presentation was excellent. You have actually covered the history in beautifully covered the concept of total pain. So thank you so much for that. So, and everyone who has given their thoughts.
I have a doubt. You are discussing about DEXA. So
yes,
how long we should give, and whether tapering dose is necessary for that?
Definitely tapering dose is required, ma'am. So we cannot actually, the thing is actually what we usually do is we'll give for a week and then we gradually taper it off. And the thing with DEXA is over time, it tends to lose its efficacy, ma'am. So long term, DEXA may not be as beneficial as before. And the only thing I was worried about initially, she was on a concurrent steroid along with this docetaxel. So I think there is something new. And if there is a cord compression or something like that, definitely DEXA will be worth trying, because there is nothing wrong with the trial of DEXA. If you give along, please.
Yes, sir. Actually, during the OPD, when the patient visited us, so we actually give him IV stat DEXA 16 mg. We didn't continue it for the home. We give him stat at that time, and it his pain obviously got relieved, and then we started him on the morphine. We just give the first cocktail thing along with paracetamol, and if his creatinine level was raised, that's why we didn't give him the diclofenac injection. Usually that also works.
Yeah, NSAIDs definitely should be avoided in this situation. But DEXA, I think, see, if the patient is going for palliative radiotherapy, so at least to bridge that gap, DEXA will be helpful. And again, in palliative, during radiotherapy, definitely he'll need DEXA, because there will be some tumor edema and then increase in cord compression. So if you start him on DEXA and then continue it to radiotherapy, once the radiotherapy's effects kick in, you may be able to reduce the dose of DEXA and then taper him off. So at least for this period, I think if he had a relief with DEXA initially, so definitely DEXA would be worth trying along with a proton pump inhibitor to prevent any.
In the event of
a question,
so actually we didn't continue it. No, it's okay.
Yeah, please.
Dr. Jewell?
Yeah, please. Sir.
Yeah, I just had a doubt that the creatinine level was, just to take the discussion further, the creatinine level was 2.1.
Yes.
So is oral morphine a safe option, or would methadone or something would be a better choice in such cases?
Sir, unless it is unless the renal function is drastically reduced, we don't need to, especially we are not giving long-lasting preparations of morphine. We are not giving continuous release morphine. So the metabolism will be doubtful in that case. As I think we can, if morphine is beneficial, there is no harm in giving oral morphine it is immediate release morphine. So even with creat 2.1, I don't think that will be an issue unless the real function is drastically reduced. We can probably give morphine, sir. It won't be an issue. It won't be an issue. Oh, and if in very deranged RFT, as you mentioned, I mean, the drug of choice would be not morphine. It would be either fentanyl or in some cases methadone, if that is cost is an issue. But in this case, 2.1, I mean, I think morphine would be fine. Ma'am, Sridevi, ma'am, any comments regarding that?
The same comment. We don't, and as far as the patient is not showing any signs of toxicity, is absolutely fine. No myoclonus or delirium, then it should be. Dr. Shrikant.
Yeah. So I'm a PMR practitioner. I work in a lot of spinal cord injury patients we see, and this quandary I've been in for a while. Patients who have metastatic bone disease with cord compression, with a short lifespan, expected lifespan of 6 months to a year. For those with neurogenic bladder, what is the general practice? Do we start them on CIC or do we keep them on indwelling catheters?
So I think what we usually do would be an indwelling catheter, I think. So we don't usually rely on drugs, but again, catheter would solve the problem. If that is okay, I think catheter would be the best option. Ma'am, Sridevi, ma'am, any comments regarding that, ma'am?
Same here. I think we prefer indwelling catheters.
Catheter, yes.
Thank you.
Maybe one last question, Dr. Nishant, please.
You had mentioned regarding the role of steroids. In the same case, if there was no cord compression and if there was no metastatic disease in the spine and if there was multiple bone mets, would you still recommend using steroids for for anti-inflammatory action, or in that case?
Yeah, I mean, see, if the pain is still morphine or something, there is definitely you feel that there is inflammation. There is no harm in trying a trial of steroids. So if it is not working after 2 or 3 days, we can obviously taper it off and stop. So there is no point in continuing. But see, especially when there is widespread bone mets and there may be some inflammation and all those things, definitely steroids can be tried. It's not a routine thing that we do, but there is no harm in giving a trial of steroids, especially if the pain is not responding to our typical analgesics. Definitely, there is a role of steroids, and we'll have to see. Because whether if it is responding, then if it is responding to steroids, you will know it almost immediately, at least in 2 to 3 days. So if it is no benefit after that, there is no point in continuing that. But definitely, a trial is definitely worth.
Okay. Thank you.
Thank you. Thank you, Dr. Jewell, for the wonderful presentation. And we had a superb discussion. Everyone was asking questions. Thank you so much for the interaction from the participants. And this is how we also learn, because then we also start thinking from the other part of it, and then we also learn many things. So as I said, this is a very mutual learning platform, not a lecture. So thank you so much for the interaction. We expect the same level of enthusiasm till the end of 20th session. Thank you so much, Dr. Jewell, for your time. Sri Priya?
Thank you, Dr. Jewell, for joining us from your busy schedule. And as usual, the expected outcome, wonderful session. And thank you everyone for joining us and interacting very well. So with that note, this is Sri Priya along with Dr. Jewell Joseph and Dr. Sridevi signing off from the TIPS Eco Hub. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, stay happy. Bye-bye.
Thank you.
And please don't forget to give your feedbacks.